Gero Nurses, Tales from the Front, is made possible thanks to support from the Center for Education and Research on Aging at the University of the Fraser Valley and the Gerontological Nurses Association of British Columbia.
Welcome back. In this episode, Lillian and Shelley speak with a relatively new Gero nurse, Prab Ganda. Well, here they are, two women who, when asked what book they would take if stranded on a desert island, both replied, How to Build a Boat. Shelley and Lillian.
Hello, greetings, and thank you for joining us, everyone. I am Lillian Hung, the president of Gerontological Nurses Association of BC, GNABC. Not much longer, because our president-elect, Dr. Sally Kenning, is stepping up to be the president soon. Here you go, Dr. Sally Kenning.
Thanks, Lillian. I will be the president of GNABC in a month, I guess. And I'm also the director of CERA, UFB's Center for Education and Research on Aging, and GNABC and CERA bringing this to you.
So this is Gero Nurses Tales from the Front, where we want to share inspirational, often very innovative, unique stories, and some of the really interesting experience of our Gero nurses.
So today we're really excited to have Prab Ganda with us as our guest. Prab is an RN and she's currently working in acute care on both a medical unit and an ACE, or acute care for the elderly unit. Prab is a recent graduate from the University of the Fraser Valley nursing program, and she actually started her nursing career right at the height of COVID, just over a year ago. And so I think she's got a really interesting perspective to share with us. And Lillian and I both really looking forward, Prab, to hearing about how you've managed some of those challenges of meeting the needs of our older adults as a new nurse and during COVID.
Oh my goodness. Wow, love to hear. And I'm really excited to talk to you. Hi, Prab. Thank you so much for joining us to talk a little bit about your experience as a Gero nurse, a new nurse working on the ACE units with our patients.
Yes, thank you for having me. I'm really excited to get to do this.
So maybe, Prab, if you can, I know you don't, working in the hospital only care for our older patients, but I also know that you've got a special interest in managing their care needs. So maybe share a little bit about what might have sparked your interest or inspired you to kind of take that focus in your nursing.
It's funny because when I was like 16 and my mom and I were discussing what I was going to do, like career-wise, nursing came up, and I don't know why, but I just knew that that's what I wanted to do, even though I had no idea what it was going to be like. I had nobody in my family or close friends or anything that were nurses or worked in healthcare at all. So I didn't really know what it was about, but I knew I wanted to do it. And then 2 years, when I was doing my volunteer hours, because you need volunteer hours as a prereq to get into the nursing program, I worked at like a long-term care place that was all geriatric people, residents, which was really fun. And then 2 years into the nursing program, we had the opportunity to be employed student nurses. And so I got to do that twice. So the first time I was in ESN was on our ACE unit. And then that was a really good experience for me. And I really liked the geriatric population. And I liked working with them. And then when I did my preceptorship, which was 3.5 months, I was back on ACE. That's where I got placed. And it was a great experience. And then now I work primarily on the medical unit that you mentioned, but it's right beside ACE as well. And so sometimes I'll work on ACE as well. But even on our medical unit, as we know, there's the majority of people on our medical units anyway are elderly. So yeah, so that's kind of my story, and just sort of along the way of being a nursing student and an ESN and then a nurse, working with the geriatric population is kind of like it's like no other population, and they're fun to work with, and so that's kind of a short little, I guess, snippet of how I've gotten into working with geriatric patients.
Wow. You said the geriatric patients, older people that you work with, they're fun to work with.
They're fun to work with. There's so many things that I like so many reasons why I like working with them. But fun is the word I use. And when I tell my stories to like my family and my friends about the patients I work with, the thing that I always come back to is that they really crack me up. And it's so funny because you can really joke with them about things that you just can't joke with when you work with younger populations. And I don't know. And they make me laugh. And there's just, I don't know, it's rewarding to work with them because, and maybe this comes from a little bit of a selfish place, but they really appreciate the sort of emotional and personal care that you can provide for them, which is so hard to do right now with staffing shortages, which is really really unfortunate. But yeah, I don't know, that it's rewarding to work with them, and it's rewarding when you can provide them with sort of that extra care. Working in a medical unit, you're like, okay, we have to give you these antibiotics and we have to do these medical interventions and we have to manage all of these sort of medical acute things going on. But when you can sit with them for 5 or 10 minutes and hold their hand and let them talk to you about their life, like, I don't know, I find that that's really meaningful, and they really, really appreciate it more so than like, somebody that's like 50, where they just need their antibiotics and want to go home or whatever it is. That's not the case for all 50-year-olds, but I don't know. It's fun. I had a patient recently who was almost 100, and he was fully oriented, very independent. I think he lives on his own, if I can remember correctly. And for, I don't know if I should say the reason why, but he couldn't have visitors. And so his daughter brought him a phone, and, she called and she was like, can I bring a phone? Like, I'll leave a note for him on how to use it. And I was like, yeah, that's fine. So I brought him this, I brought him the iPhone, and he had no clue how to use it at all. And he was like, in my 90 whatever years of life, have never held a cell phone. And so I sat with him. I also had 7 patients, but I was like, listen, like, he needs to talk to somebody in here because he can't have visitors. Like, this is, we've got to be able to connect him with some family. And so I sat with him for probably 20 minutes, and we sat on the edge of his bed together. And I taught him, how to phone. I had to teach him how to phone his daughter from an iPhone. And I was like, okay, so the first thing you want to do is press the home button. And he was like, where's the home button? And I was like, okay, here's the home button. You press this. And he, and then it gets to the home page with the apps. And I was like, okay, so these are all of your apps. Do you know what an app is? No. And I was like, wow, this is so wild, because like most of my geriatric patients, a lot of them have iPhones or whatever, Samsungs, and they know how to use it. But I was like, here's this person who's almost 100, and he doesn't even know what I mean by, to click the phone app. He didn't know what I meant when I said to scroll through your contacts. So even just being able to provide that for him, and just sort of getting him some contact and providing some personal emotional care.
Wow. So it's not really about having access to the phone. The phone is right there. But if you were not there to help him, then the phone means nothing.
Yeah. And then when you think about the staffing shortages, I mean, I think all the nurses I work with are incredible, but not every nurse is going to want to or be able to sit there and teach somebody how to use a phone. And, I would never blame the nurses for that, but it really sucks for these patients who are stuck alone for the duration of their time in the hospital. Yeah.
Very confusing.
So it kind of strikes me that you're using your Gero nursing lens there. So, you actually saw what needed to be done, and you knew that just a little bit of time would kind of solve a problem and lead to a much better quality of day for him. I don't know if we could argue it's quality of his life, but it certainly, it makes life much better for an older patient in hospital. And I think for some nurses, they just don't quite see it. Not that they wouldn't want to provide an opportunity like that, but somehow they miss that.
Totally. Yeah, no, I agree. I think, I mean, it's just a different skill set. And as you said, it's just a different lens. And I think I really love my geriatric population. And so I try to see those other aspects of what they need.
So you told me a story a while ago that resonated with me and definitely showed me you've got a Gero lens. And that was with an older Punjabi man. I believe he had dementia. Maybe you could share that story again and what you did. So simple, but so effective.
Yes. Yeah. We had this patient. I think this was on our ACE side. And I mean, we get so many patients like this. He was a patient, he had dementia. It was pretty advanced, I would say. And yes, he was Punjabi speaking. And so, obviously as an Indo-Canadian person, those, I can also see the struggles that those patients also have, and they have dementia. So you pluck them out of their routine, you put them in a hospital. All of us are in PPE and masks. And they can't speak English, and you can't speak Punjabi. I mean, I can, but a lot of nurses can't. So you put them in this situation that's so vulnerable for them and confusing. And so, so this gentleman, he was lovely. And he was constantly wandering around the unit. And of course we were short staffed, and, we're sitting there and we're all trying to do our stuff and frantically trying to chart. And he's walking up to everybody and saying whatever he's saying and asking all these questions and just wandering. We can only get up so many times to redirect and have him sit down so he doesn't fall because he's not walking with his walker. But I mean, he was so sweet. So I was like, okay, this is what I'm going to do. So I pulled him over to my side of the nursing station, and I told him just to sit beside me. I'm like, okay, if he can at least sit beside me, he can watch what I'm doing. And it was great. He was able to sit there for it must have been like 10 minutes. But it was 10 minutes where he could sit and he was safe. And I could also make sure that, he wasn't going to fall. And I could also kind of do my work. And, and then we gave him a piece of paper to write on. And, we asked if he could write in Punjabi, which he could. And so he started writing. And it was a nice moment to be able to sort of, compromise and have him be safe and have him sit with me. Cause it was kind of the only thing that I guess settled him. On the other side of the nursing station, he was wandering more, but I was like, listen, you know what? We'll see if this works.
You were kind of both charting that. When you told me that story, I had in my head the vision of the two of you sitting at the nursing station, both charting.
Mm-hmm. It was great. And is it following policy and infection control rules and blah, blah, blah? No. But you know what? If it's going to keep him safe and I can also get a little bit of work done, you know what's it to us? Okay, sure, we'll cavi wipe the area once he's gone, big deal, right? But you got to break a couple of rules here and there.
So breaking the rules for patient benefit.
Mm-hmm. It kept him settled, and I don't know. That was a funny moment.
I think, Lillian, you've done a little breaking rules for patient benefit, it seems to me.
Well,
not too much, but I sometimes you have to.
Well, I am much older than Prab. So Prab, you are a young nurse. So to be there to break the rules. So you're bold and brave and you know what you're doing.
Well, I don't know if I would say I know what I'm doing, but yeah, I would say, I'm pretty vocal on the unit, and I think if you asked my management, they would sure tell you that.
Yeah, that's something about you.
Try to advocate, and sometimes you got to push back a little. You got to advocate for your patients, and that doesn't always please everybody on the management side, but we're just here for our patients.
So advocacy is a real cornerstone of nursing practice. Mm-hmm. And when we think about marginalized groups or groups that need more from us than others, like our older patients do, the importance of advocacy just gets ramped right up. And I do know that you've been a strong patient advocate. And that is, I think, really impressive considering both the time you started and the length of time you've been nursing. Mm-hmm. So maybe share a little bit about what that felt like for you, because you would have been, pretty vulnerable as a brand new nurse, and you enter a situation where you're not particularly well resourced. And I know that you advocated for both for your own practice and for the patients you were caring for.
Mm-hmm. Yeah, I mean, it's interesting being new, and I graduated into our pandemic. I think I started working as an RN right before the third wave. And the third and fourth wave were horrible, COVID-wise. So you get thrust into this pandemic as a new nurse, and so it's been interesting because and we're lacking so many resources, and so having to really advocate for your patients, and you kind of hit the ground running as a new nurse into a pandemic. It's been interesting, but I think I would really have to credit, partly it's my personality. I'm not a shy person. I'm not a quiet person, volume-wise or opinion-wise. But I think also I really have to put a lot of credit towards the nurses I've worked with. I got, I think, really, really, really lucky in my ESN experience and in my preceptorship experience. I got a really great preceptor who I'm still friends with now. And also when I started working, the units that I work on, we have very vocal nurses. And so just having the opportunity to look up to them and seeing that, okay, I am allowed to advocate for my patients, and I am allowed to push back a little bit, and I still can be professional while also advocating for patients. And so I think just seeing sort of the nurses I work with and having those role models was helpful for me.
So when you see new nurses come on or student nurses come, I'm sure you've got a few words of wisdom to share with them and encourage them to engage in some of those ways.
Yep. Oh, for sure. Yeah. I have, and I'm still a new nurse. It's been a little over a year of working as an RN, but the newer nurses that are coming up and working with us, I have a couple of them, and they're like, hey, Prab, like, this is a situation, like, should I, push back here? Or should I say this? Like, I think this patient really needs this. Like, what do you think? And my first answer is always a very confident yes, absolutely, do it. Call ICU, suggested these recommendations to the doctor, ask this of the PT, or tell this to the PCC, this patient needs this, and you've identified that. You're the nurse, you know what they need. I have very, very strong words for the newer nurses that are like, hey, like, do you think I should say this? I'm like, yes, you should. You are right in this scenario. Absolutely. And I use my line often, which is, listen, you're not going to lose your job because you're advocating for your patients and you're advocating for patient safety. So there's nothing stopping you here.
Oh my goodness.
And I say, and listen, if you do it and you get told no, chart it. And I'm like, listen, now you've done everything you can.
I love it. I love it. So you talked about being vocal, advocacy. So you have a lot of confidence. So I wonder, like, if you have like young nurses that, it's not everyone have that kind of confidence like what you have. Yeah. So what are some of the advices that you may give to others that they are new and trying to enter the career, want to have the same level of confidence that you have to advocate for their patients, to find things that are rewarding than when they go to work?
That's a good question. Yeah, I mean, personality differences is so important. And I kind of say the same to everyone, and not everybody is as vocal, and that's okay. I can't, you can't expect everybody to be as loud, but I don't know, even we have some nurses that are more quiet and less intense, but they're all still good at advocating. And if I would say the same thing, really.
Does the environment make a difference? Like a culture, the environment, a culture that feels kind of safe. It's okay to speak up.
Yes, totally. I think that's important, to have nurses around you that you can trust and that you can come to. I know, I ask a million questions every shift, even still. And I know the nurses on the unit that I personally trust, and I know that I can come to. When we have clinical students on the unit, I kind of tell them 3 things and as my kind of rules for them. And one of the things that I tell them is, I will only be annoyed at you if you don't come to me and ask your questions. And I tell them I will only be annoyed if you don't communicate. And I tell them that there's no dumb question. If they need to ask me 300 questions, that they can ask me all 300 questions and I won't be annoyed. So I think that's important, is sort of creating that atmosphere of trust.
So I'm thinking about what it would have been like when I started nursing. It was 1988, and it was a much safer time and a much better resource time. No COVID, a really lovely mix of very senior nurses and new nurses. But I keep imagining the stressors there. And one of the things we know that's come out of it is this really disproportionate impact on older patients. And I wonder if you can maybe share a bit about some of the ways our older patients were impacted, in much more negative ways.
For sure. Yeah. I mean, it's so hard. I mean, just when we look at recent times from the pandemic, we had, our emergency was, way, it was empty because nobody wanted to come because they were scared of COVID. So, we had so many conversations because our medical unit was used as the COVID unit and is still being used as the COVID unit. But we had so many conversations of like, okay, where are all of these people that would normally be in emerge right now. Like they're at home sick with chronic illnesses that aren't being managed. There were so many things that shut down, and so many things, that got waitlisted. And, we had a lot of conversations about these people that are at home and not getting the care that they needed. Especially, that's important for our geriatric population. They need access to healthcare resources. So that was one thing. And I mean, I will be a broken record because I will always talk about short staffing, and I will never stop yelling that from the top of the hill that we need better staffing, and it will solve almost all of our issues. But I mean, and that's been a pre-pandemic issue, and even more so now when you think about short staffing. Like I can't mobilize all my patients. I can't give them the proper, hygiene and personal care that they need. I can't give them the proper, emotional care that they need. So it's hard because then, when you have 7 acute patients, you can't prevent hospital pneumonia. You can't prevent the UTIs. You can't prevent pressure injuries, all of these things that, geriatric people especially are susceptible to. We just don't have the resources and capacity to prevent all of these things, and prevent all of these things that keep them in the hospital longer, which is, I mean, truly unfortunate. I feel like I've watched a lot of our older population stay in hospital way too long than they needed to, and then they get a hospital pneumonia and they end up passing away. And you can't point that directly at one person or one nurse or one doctor or one PT, OT, RT, or PCC. It's, it's a systemic issue. So, I mean, there's so many issues. And these geriatric, they don't get the care that they need, and they need more time, than say somebody that's, 40 years old and is oriented and can walk and, can clean themselves.
So that was loud and clear. Can you tell us, like, short staffing? Can you tell us what that was like?
Yes. I mean, I could talk endlessly about it, really. It's been very rough. Our ACE unit, I think they have, we're sticking people in the hallways, which, I mean, is just horrendous. And we all hate it. So we have all of these people in the hallway. On our medical unit, we've put people back in the hallway. And they've started on both of the units I work on our ACE unit and med unit. We have semi-private rooms that have 2 beds, and then private rooms which are just 1 bed. But all of the private rooms that we can double, we've doubled. So we're sticking 2 patients in a room that's meant for 1, plus all these added hallway patients, but no extra nurses to attend to these extra patients. And they don't stop filling the beds if we're short nurses. So, we could be short like 3 nurses, and we're, in the morning, you're still getting 2 people up from emerge. And I mean, I don't know.
How many nurses do you have on a unit when you're short 3 nurses?
What's that?
How many nurses that you're supposed to have on that unit during the day when you're short of 3 nurses?
I mean, ideally, both of the units are 20-bed units, but now they're like pushed to 28 and 29 patients because we're sticking them in the private rooms and in the hallways. So when we're short, if we only had the original 20 beds and we had 4 nurses on, we would be a 5 patients to 1 nurse ratio, which, is doable. Not always, but it's doable, manageable. But now it's like every nurse has 7, 8, 9, 10 patients. We've had a 12-to-1 ratio. So yeah, it's not been good.
Wow.
Yeah.
Not good. Yeah.
Good. Yeah.
And especially when you have to think about like, what are the things that I'm going to have to let go
Exactly. And
to provide. Yeah.
exactly. Because you have to start compromising patient care because you physically, I have gone through many, many, many shifts without a single break, without a single bathroom break, without taking a sip of water, because there's just that many things to do. And yeah, I mean, it's the worst. And you think about, again, like our vulnerable populations, I mean, it's not good. We recently had one of our hallway patients who was an elderly lady. She was not oriented. She was what we call a total care patient. So she's basically bedbound. And I wasn't her nurse, but my partner was, and she was fecally loaded, and she had to give her an enema and had to disinfect her in the hallway. And so when you think about our older population, they're already so vulnerable. They already lose, a lot of their dignity just by being in hospital and, being treated the way that they're treated, and they don't get the proper care that they need. And then on top of that, you stick them in the hallway and then have to do an enema and disinfect them. And then they have an incontinent bowel movement. Then you have to do a full change. I mean,
it's very bad.
That's just, there's nothing worse. It's horrible. And that's sort of how it's been lately, almost every day. So
like, okay, this is really, really bad. And it's very extremely challenging. But in the beginning, you said you love working with the population. You love your job.
Yes.
When the nurses are put to work in these like crisis situations, that they are so short staffed and so much work to do, and they are put in at risk of having moral distress. How do you find the rewards? And you seem to have the confidence, and you're able to see those rewards and to spend those moments with your patients.
That's a good question. And I don't even know that I could answer that very well. I know for me, what keeps me coming back right now is the staff that I work with and the patients. We are hanging on by a really thin thread. But, I come back for the staff that I work with and the patients that I get to work with. And it's hard. It is morally distressing because none of us came to do this job. None of us went into nursing to do a bad job. I love the job that I went to school for. I don't love the hospital politics, and I don't love having 7 patients every time, because you don't get to provide the patient care that you want.
It's not possible.
It's really not. And, with the older population, when they start telling me their life story, I want to be able to hold their hand and sit there and listen. But you just can, and it's unfortunate. So I don't know how long this will go on and how long people will stick around.
So we're in a really like challenging times, because I'm thinking about like even people like you, that you are so extraordinary. But, when you think about the risk that we have, that it's just not sustainable. So how are we going to retain nurses, especially people like you, good nurses?
That's the golden question. I mean, I will always keep saying this. We need more staff, and we need the support, and we need the funding. And I don't see a long-term solution other than having adequate staff. And I don't just mean nurses. I mean our care aides and our PT and our OT, and the people that actually are in the rooms with the patients doing the physical work. I personally don't see another way. We keep filling needs with short-term solutions, but I don't know. It's not sustainable at all.
It's like the system really hasn't grown and evolved. And even on the simplest level, just looking at the population of where we're all living, population has increased tremendously, but our resources haven't kept pace. And then you layer on a pandemic and a crisis, and that just shines the light on all of the holes in the system, because we were really vulnerable before.
Yeah. And then when you think about Canada as a whole, I mean, we hear it all the time. It's an aging population. And this, we're not going to all of a sudden start seeing younger patients. Yeah.
But we need young nurses. We need a lot more a massive amount of young nurses like you. But when we recruited nurses, we have trained nurses when they come in the workforce, and we can't afford to lose them.
No,
this is true. And as much as we need our younger nurses, we also need to retain our senior nurses. In my first, maybe in the first 6 months, every time I came onto work, the first thing I did was look at the whiteboard and see which senior nurses I was working with, because I was like, okay, if anything goes wrong in my shift or I need to ask a bunch of questions, who am I going to go to? Right. And when you think about the senior nurses, they've seen way more than I have, and they know what nursing has been like and what the progression has been like. And I don't know, they really are angels sent from above, and we need to retain them as well.
You're right. You're absolutely right. Then the leadership support, if they say, okay, we had it, and they leave and there's no senior nurses to coach and support the young nurses.
Yeah, totally.
So we need somebody in those positions of power to have a very broad, fulsome look at the system. So if you had the Minister of Health here right now, and you could tell him one thing, you've got one wish, Prab, or one thing he really needs to know, because I'm sure he listens to Gero nurses.
Yes, he does.
What would you tell him?
Oh, I would have a lot of choice words. No, I'm kidding. Really, it comes down to funding and funding the right positions, which from my perspective personally is, as I said, the staff that actually does the physical work with the patients. You need to pay us more, maybe some better benefits. And also I think it would be beneficial to open up more seats in nursing programs, and having more seats for LPN to RN bridging, for those programs to open up more seats there, and get some more nurses. Cause I don't know, this healthcare system is, it will collapse, and it already feels like it is. That's what I would say.
I'm thinking we're really seeing the importance of the bedside nurse is what we're seeing. And for me, my personal hope is often I see the best and the brightest of us absolutely excel at the bedside. And then before we know it, they've taken kind of a middle management role somewhere in the health authority, because of course they are so capable, but I'm hoping that they stay at the bedside for a while longer. That's where it all happens. And so my personal hope, Prab, is that you stay for a while at the bedside.
Trying my best. Around as long as I can, and I will hold on to hope that things will change, and I will hold on as long as I possibly can, because I love it. Bedside is it's fun and it's exciting, and you learn so much so quickly. And it's not fair that we have to leave bedside for really just for our own sanity, because that's why a lot of us leave bedside, right? And that's not fair, because a lot of us don't want to, but some people can only hold on so long when you have 7 patients or 10 patients. But I will try my best to hold on.
Yeah, it's sustainability though. People stretch like too thin, and in the long term, it's a marathon. It's not just one day that we work a little bit harder. Yeah,
Definitely. Yeah.
every day. Yeah, so it needs to be a healthy workplace so people feel healthy to go to work and they could find joy and fun and reward. Yeah.
Yeah, definitely.
And I think when you've got that kind of a workplace, then we will see more people take a Gero lens, take the time with the older person, think a little bit more deeply about the complexity of the older patient's needs and not just gloss over it or rush through it.
Yes, I totally agree. And I hate to admit this, but I recently just stopped picking up on our ACE unit because it was too short, and I left every shift feeling like a horrible nurse because it's true, like as much as every patient needs your time and your energy as the nurse, the older population, they needed a little bit more, and you need more time with them at the bedside, and you need more time for them at your computer, because for me, like, I need to know a lot more of what their baseline is and a lot more of what their discharge is going to look like and who needs to be involved in their discharge to go home safely, right? And I think, the older population, they do need more resources as a whole to go home. I sent home a patient the other day because she was young and independent, and she got switched to oral antibiotics, and it was like, okay, go home, see you. And it took me 5 minutes to discharge her. But when you think about our older population, you need the time to look into their history, look into what they need, have time to even think about what they need to go home. But you simply can't do that in these current circumstances, which, gosh, it really is horrible. But yeah.
Yeah, it's true. It needs to base on the needs. Yeah.
Definitely.
Wow. I just want to thank you for taking the time to come to talk with us. And I certainly have learned a lot and feeling inspired, especially, how you're able to find that joy and fun to work with the older population despite the difficult situations that we are in at this time. Yeah.
Oh, well, thank you guys for having me. I love chatting nursing. I really could stay here forever.
And you know what? Lillian and I love chatting nursing too. So, but yeah, I want to echo what Lillian said, Prab. And I also want to thank all our listeners for taking the time to listen, and encourage everybody out there listening. If you can think of someone that we should chat with on an upcoming episode of Gero Nurses, please email us at lillian.hung@ubc.ca or shelley.canning@ufv.ca.
Well, so until next time, and we hope you all stay safe and stay healthy. And we'll talk to you again next month.
Thanks, Prab.
Thank you, guys.
And that's the show.